I would like to welcome everyone. Again, this is one of our continuing education series. We talk about emergency medicine and critical care topics in these sessions. And we've been doing this session with HAPSA-Nepal for the last, we've been doing it for a while with HAPSA-Nepal. We've been doing it for a couple of months now. And today we're talking about approach to acute coronary syndrome in resource-limited settings. And before I introduce our speaker, I would like to invite the president of HAPSA-Nepal, Dr. Ramu Khorel, to tell us just a few words about HAPSA-Nepal and introduce the session and to welcome everyone. And I think Dr. Ramu wants to share his screen, so Prakash will stop sharing your screen for just a short bit.
Thank you so much. Sunira sir, mera awaz?
Sunira sir.
Okay, and then you can see my screen here?
Mm-hmm.
No,
Okay.
not yet.
Oh, I think I don't know whose screen this is, but yeah.
You can see
I
the
think
screen.
It's Prakash's screen. Okay, we can't see your screen, Ramu.
You can't see it? Okay.
Yeah.
Okay, let me see.
You may have to share it again.
Okay, I'm trying here. Let me see. Stop sharing. Okay. Now there's no screen, right?
Correct, yeah.
Okay, great. Now there should be a screen. Let's see. How about now? Can you see it?
Mm-hmm. This is still Prakash's screen, Dr. Prakash Acharya on the head. So, okay, yeah, I think this is
No, it's Ramu Khorel's screen.
Yeah.
Oh, okay. Thank you. Okay, you can see my screen. Okay. Namaste and thank you, everyone. Thank you. Continue to share. Okay, thank you, Dr. Suvarna, and welcome everyone to the LEED series. As Dr. Suvarna said, this has been ongoing for a while, and we are excited to be partnering with him to bring this, within HAPSA-Nepal. So today we have Dr. Prakash Acharya, who Dr. Suvarna will introduce in a second. But before we move forward, I just wanted to provide you a brief introduction of HAPSA-Nepal. So HAPSA चाहिँ health advancement programs to serve all भनेर हामीले 2010 मा we started this organization starting in India, and in 2013 we started working in Nepal. So we've been working in Nepal for over 13 years now, and really our goal has been to advance equitable care in remote regions of Nepal. So all our work involves working in rural parts of Nepal, but also sort of advancing education, integrating frontline responders. So right now, our core focus areas really focus on 4 programs. एउटा चाहिँ हामीले Nepal Lifesaver program भनेर run गर्छौं, which is focused on police, teachers, frontline responders, response in CPR and choking first aid, as well as bleeding control, which we're going to be adding in the upcoming future. So that's a big part of the program. Dr. Kamal, who is actually here, is lead of that program. So if you have any questions, you can definitely ask him. The second part of our program is with pre-hospital trauma and emergency care. We're mostly based out of Acham. We partner with Bailpata Hospital and the far western government. Dr. Mandeep Pathak, who has joined here, he is leading that wing, and a lot of activities going on in that front as well. Third, we run the Poison Center that is based out of Dhulikhel Hospital, which is Nepal's only institution-based poison information center. We started this a number of years ago, Tribhuvan Vishwavidyalaya. Once we finished the pilot, this was moved to the Dhulikhel Hospital, so it's running from Dhulikhel Hospital. I'll share you the phone number. It's 24/7. So if you have any poisoning cases, I really hope that everyone that had joined here can make a call to the Poison Center, not because you might need help, but also because it helps us track the poisoning cases and create data for our country to move forward in the future. And then finally, we work with a lot of programs around point of care ultrasound, rural trauma देखि, rural emergency देखि लिएर. So these are sort of the brief overview of the programs that we do. We do a lot of work in disaster response as well. So you can check our information out in our website there. Briefly, Poison Center ko phone number say, if you don't have it, please keep this in your mobile 011-490-877. यो चाहिँ 24/7 नै उपलब्ध हुन्छ. We have our trained specialists there that answer the call. अनि Poison Center को पनि हाम्रो monthly webinar हुन्छ. We teach quite a bit. We've done webinars for now 2.5 years. every month. So there's high, fidelity materials that you can go and watch on our YouTube using this QR code. And then finally, I want to share your Mako 8 and 9th ma. We have partnered with the Far Western government and the Bailpata Hospital to host the 4th Rural Trauma Conference. And Dr. Mandeep and our team, we've been doing this the last few years in a much more smaller scale, and it has been going really well. And this year we're doing it in a little bit larger scale and partnered with the Far Western province. यो चाहिँ 8 र 9 मा छ, नेपालमै छ. And we'll have a pre-conference workshop that will focus on ultrasound, point of care ultrasound, on fracture diagnosis, DVT ultrasound, and EFAST. And we'll have a great speaker session, and this will happen at Bailpata. So you can use this QR code or go to our website to learn more about this. And I hope, if you're in Nepal or even outside and you want to join, please email us or just register, and we look forward to seeing you. And with that being said, I will hand this over to Dr. Suvarna to introduce our wonderful speaker today in our session today. Thank you.
Prakash, while I'm speaking, you can go ahead and start sharing your screen. So I would like to welcome all of you. Thanks again. Thanks for your continued participation. And Dr. Prakash Acharya and we went to medical school together, Institute of Medicine, Tribhuvan University, 26th batch. We started back in 2005 and finished our school together 2012. He came on to do a residency in internal medicine at Rochester General Hospital, and then went on to do cardiology fellowship at University of Kansas Medical Center. Currently, he works at the Missouri Heart Center as an interventional cardiologist, and a longtime good friend and an excellent person. So we're excited to hear from him. Thanks for agreeing to do this session, Prakash. So I would like to hand it over to you.
Thank you, Suvarna. Thank you for the introduction, and thank you for the opportunity to discuss with you guys today about approach to coronary syndrome in a resource limited setting. So just to give you a brief background about where I work and how we work, I work in Columbia, Missouri, and we have a catchment area for over 350 kilometers around where we live. And most of the areas that we deal with at Missouri Heart Center are rural settings, as rural as it can get in the United States. Because the nearest, today I'm at a clinic which is about 150 kilometers from the hospital. And most of the patients that are taken care of here go to urgent care centers or rural clinics as there is no hospital nearby. So the setup today is also kind of goes with what we are discussing about. So let me start with disclosures. So I have no disclosures. I'm still working on them, but hasn't happened yet. I do want everybody to, I want this to be very interactive. I have a lot of questions that I want people to answer. And if you guys could just type menti.com on your cell phone or laptop, whatever you're watching on, and put this code in, because every time a question pops up in the screen, it will allow you guys to give an answer so that we can see a live feedback while I keep on going ahead with my presentation. So I'll let this play on the screen for the next minute. I do want everybody to participate so that we can see where everybody is practicing, what the practice looks like, and then we can talk about how we can improve the practice in a rural setting for management of acute coronary syndrome. All right, so I'll give you a few minutes. If you can do that, just type menti.com and just put that code in. That will help you answer the questions. And every time a question comes, that code will also be displayed. So if you don't get the code right now, but just make sure that you put menti.com to your browser. It'll ask you for a code there. All right, I'll move ahead. The code will display every time the question comes also. Okay, so let's start with a case. So let's say you're posted at a healthcare facility in Kalanga, Bhutan, as an emergency room physician, and the nearest hospital to you with a cardiologist and primary percutaneous coronary intervention service is in Butwell, which is more than 4 hours away. So you're working there. A 62-year-old farmer comes. He has medical history of uncontrolled hypertension, type 2 diabetes mellitus, and prior history of tobacco use. He didn't want to come to the hospital, so his wife brought him in for chest pain at around 2 p.m. in the afternoon. The patient tells you that the chest pain had started around 8 a.m. in the morning when he woke up. And you perform a history and examination. His blood pressure is 169/88, and his heart rate is 98 beats per minute. You examine the patient, and the patient has crackles over the bilateral lung bases. S1 and S2 is heard. You don't hear any murmurs, and the patient is alert and oriented. And you order an EKG. All right. Oh, so it's not letting me. Just give me a second. This, I'm not sure if this is working here. Okay. Okay, I'm not sure if this is going to work or not. Okay, so this was supposed to be a poll question. I think the rest of the poll questions are working, so I'll go ahead with this. So the question was, what is the recommended door to ECG time, meaning time between the patient arriving in the ER to the ECG being performed? What is the current goal? And I was trying to poll you guys. I'm not sure if my poll system is going to work or not, but the current recommendation is 10 minutes. And now the next question is, at your health facility, how often do you meet the goals for door to ECG time, which is 10 minutes? So if you can I'll give you a few seconds to respond, and we'll see.
Because this may be skewed a little bit because some of us from the US are also responding. So
That's right. That's right. Yeah, no, it's good to see most of the time and always there, which is great. And okay, so it looks like yeah, it might be a lot of the US population too. But yeah, ECG door to ECG time of 10 minutes is the current recommendation. Believe it or not, it's more difficult to do than what it looks like, because even at our hospital, which is a STEMI center, we track this, we discuss about this every month, and still there is about 15 to 20% of the time when we still miss it. And so let's move on from this. So there are three major aspects of acute coronary syndrome management. And the first aspect is, what is the process? What is the process of dealing with a patient who comes in with chest pain? The second question is, what are the time goals that we want to abide by? And why is it important to abide by those time goals? And then the third question is, pre-perfusion strategy, what kind of medicines do you do, and all of that. As you can see in this figure here, when a patient comes in with chest pain, all of us are trying to differentiate whether the patient has ST segment elevation MI, which will need rapid assessment and management, or is it just a non-ST elevation MI, where you have a little more time to work up the patient and see what is the best course of management. And you can see that it's all EKG changes that we look for. We also send for biomarkers, but again, in the case of acute STEMI, the biomarkers might not be positive because it takes about 2 hours for troponins to be elevated. And even if you have high sensitivity troponin, it at least takes about an hour to be elevated. So in a resource-limited setting, the first step always is to build up the process for chest pain management. Because to make sure that the EKG gets done within the first 10 minutes, training of the staff regarding the time sensitivity of the chest pain management is going to be very important. And it starts from the registration, or the first person who meets the patient when they enter the emergency room. So it starts from them. So this needs a thorough training of the staff and a process build up so that we can ensure that we can get to those patients as soon as possible and have the EKGs done as soon as possible. And the other important thing is, it's not only the first EKG that's important, because tracking the it's not, because 11% of the time, STEMI patients can have normal EKGs. So you do want to make sure that we repeat the EKG, serial EKGs, to make sure there is no ST segment elevation. There is no certain timeline or something in the guidelines that tells us how frequently we should do it. At our center, we do it every 15 minutes if we are not convinced that this is a non-STEMI, and we think that it could be a STEMI, we repeat it every 15 minutes until we're convinced. But again, it differs according to centers also. And the important thing here is to try and track ECG time in the emergency room for STEMI patients. It was not something that we were practicing at when we are a resident or a medical student. And I'm not sure if things have changed now, but yeah, tracking helps you see where you are and put up goals and then try and get there. So let's say, going back to a case, the patient, 62-year-old guy, comes in, and this is the EKG that you see. I'll just give you a few seconds to just look at it. I mean, the ST segment elevations are very apparent there. As you can see, the patient has ST segment elevation in lead 2, 3 AVS, and V2 and V3 also look suspicious there. You see some reciprocal ST depression in 1 AVL and V6. So the question is, so whenever you have an EKG that's being performed, it is going to be important that you make sure that you view how the EKG is being done, because it's a very common fallacy. It still happens with our staff here, despite multiple training, because every time there's a new staff comes in, and you see that they put their V1 and V2 leads in the second or the third intercostal space, which is not where you want to do it. You want to put that V1 and V2 at the fourth intercostal space, and then V4, V5, V6 is at the fifth intercostal space. Because what happens is, if you don't properly place the leads, sometimes, just because if you put V1 and V2 is in second or third intercostal space, you can get false ST segment changes in those leads, and that will make you worried about ST elevation, where it's not a true finding. So yeah, just make sure you watch and make sure that your staff is trained with EKG, the proper way to do EKGs. And the most common fallacy, as I mentioned, is V1 and V2 in the second or third intercostal space. As you can see in these tracings here, this is actually a young patient coming in with a different reason, and they put V1 and V2 in lead in the second intercostal space, and you can already see that the ST segment appears elevated there. And the current guidelines suggest that you diagnose ST elevation MI if you have more than 1 millimeters of new ST segment elevation in 2 contiguous leads. So it has to be lead 2 and 3, or 3 and AVF. It has to be V3 or V4. It has to be 2 contiguous leads. And the place that you measure these ST segments is at the J point, as you can see, if you can see my pointer there. And that's where you measure your ST segments. And for lead V2 and V3, there's a different criteria. You don't go with only 1 millimeter of ST changes. In males more than 40, you go for 2 millimeters, less than 40, you go for 2.5. And in women, it's 1.5. It's a little complicated. So if you are making a diagnosis of ST segment elevation MI just based on leads V2 and V3, make sure that you're aware that the criteria is different. It's not 1 millimeters. And yeah, as you keep on practicing this, it'll be second nature, but just make sure that adult males more than 40, which are the most common age groups that you get STEMI in, it's 2 millimeters for those leads. And depending on where your ST segments are, we can actually guess where the blockages might be. It's, I mean, EKG interpretation and all that is outside the scope of what we're trying to talk today, but just putting those EKGs out there. The first EKG shows ST elevation in 1 AVL, V2 to V4. It's like an enterolateral MI. It's also in V5 actually. And this patient had a LED with a diagonal involved that was occluded. You can also see the second EKG where it's lead 1 in AVL, and this, we call it high lateral STEMI. It's in a diagonal branch. So what I mean by this is where you have ST segment elevations will determine and tell you where you could find a blockage. But again, that's for another discussion. Now let's go to our patient. And all right. I already have some responses there. I'm not sure how, but so yeah, let's look at the EKG here. And as you can see, this is our patient. You see ST segment elevation in lead 2, 3, and AVF. And what would be the next step? All right, I have at least about 50% there, and looks like most of the votes is for going for aspirin. All right, the answer is to repeat the additional needs, because this part is important, okay? Because whenever you see patients with inferior ST segment elevation, meaning if you see lead 2, 3, and AVS, got to make sure that there is no right ventricular infarct. And I'll talk about why this is important, okay? So what you need to do is, let's say you have your EKG leads, you just need to take out V4 and put it on the other side, exact location on the right side. You don't have to transfer everything else, because V4R is the one that has the best diagnostic accuracy for diagnosing right ventricular infarct, okay? And the reason, and as you can see that we flip the V4, and in this, you see there's ST segment elevation in V4. Whenever you have ST segment elevation in V4, it tells you that the right ventricle is infarcting. This is important because whenever people have right ventricular infarct, they are very sensitive to any medicines that you give. So when you are getting an EKG, when you see the patient has 2, 3 AVF, make sure that you take that V4, flip it to the right side, and see what the V4 looks like. If the V4 does not have ST segment elevation, you're good. It's just an inferior infarct. But if the V4 has ST segment elevation, right ventricular infarct has to come to your mind, all right? Because 40% of patients with inferior MI have right ventricular infarct. And if you have right ventricular infarct, and if you give them nitro, even sometimes sublingual nitro, their blood pressures are going to tank. And there's going to be hemodynamic collapse in a lot of these patients. I mean, despite our best efforts, I mean, this still happens. Like the EMS is called to the field here, and they do an EKG, they see inferior ST elevation MI, and then they give sublingual nitro, or they start the patient on nitro drip. And when the patient, they're doing that to relieve them of symptoms, but that in fact causes hemodynamic collapse. And when you find the patient in the emergency room, they are hypotensive, sweaty. So yeah, make sure that you always flip that V4 to the right side to make sure there's no right ventricular infarct. And in these patients, you don't want to do nitroglycerin for anginal relief. You want to give them fluids, and especially if they need, their blood pressure is low, you want to give more fluids. And if fluids is not important, then you might have to use vasoconstrictors like phenylephrine or norepinephrine to help with their hemodynamic scales. All right. So whenever you see inferior ST elevation, always try to flip that V4 to the right side. So let's go to the next one. So it's a different patient, 68-year-old male presented with chest pain, and EKG was performed. So is this a STEMI? Okay, we have some responses trickling in. There are some yeses, there are some no's, so I think there's a good split there. Okay. All right, I think we have about 50% responses, and there's a split between yes and no. There, at least 1% needs more information, or two now. So let me see if I skipped a slide. Yeah. So the answer there is need a little more information, okay? Because if you look at this EKG, this is another nuance that you don't want to miss, is you look at the EKG, everything looks, there's no ST elevation. But whenever you see ST depression in lead V1 to V3, that is more than 0.5 millimeters, and the T wave is going up, you want to make sure you get a little more information before you do anything else and disregard this as a non-STEMI. The teaching says get the posterior leads. You can put V7, V8, and V9 on the backside. Like V7 goes on the posterior axillary line, as shown here. V8 goes at the tip of the scapula. This is all in the fifth intercostal space. And V9 goes in the paraspinal region. And that's the teaching. The last time I did a posterior lead was probably about 3 years ago when I was a fellow, when I had to show to my attendings that I was following the protocols. But usually we don't do posterior leads because the easier method is you take the EKG, and the second picture, I've just turned the EKG upside down, and you can see that the ST depressions, once you flip it, you see that it appears as ST elevation in V2 and V3. That is usually enough to diagnose posterior MI, okay? So whenever you see an EKG, it looks good, there is no ST elevation, but you see these worrisome ST depressions with upright T waves in V2 and V3, you want to make sure that there is no posterior MI. Posterior MI usually tells us that there might be a large area of infarct and all of that. Yeah, you can still use, you can use nitros. There's no nitroglycerin relationship to posterior MI, but it just tells us that there's a large area of infarct, and these are very commonly missed. They account for at least 40% of all the STEMI that are missed. Okay, so that's our patient. So ECG has been done. We did back to our original patient. He had an inferior ST elevation. We did a V4 on the right side, and there is ST elevation there. So we know it's a posterior, it's a RV infarct. We did not give the patient nitroglycerin. We gave him fluids, and then we move on to the next step. Troponin testing. Do you have emergent troponin testing wherever you guys are practicing? I just want to get a sense of how things are where you're practicing. Okay, we have about 50%. It looks like emergent troponin is available, which is great.
Prakash, it may be, I don't know if you're going to ask that question. It may be interesting to ask if those troponins that are available are indeed high sensitivity troponins or the standard old troponins that we used to have. And whenever you're ready, there's another question in the chat also, just to follow up on that. What if NSTEMI of anterior lead is misunderstood as posterior STEMI by Dr. Acute Acharya? So my question first,
yeah.
What are these all high sensitivity troponins? So most participants, more than 50%, like I said, have, like most of them have said troponins are available. I have an answer in the chat that says no, those are not high sensitivity troponins, but it may be interesting to just think about that. I don't know if that makes a lot of difference in terms of what you're going to say next, but yeah.
Yeah, no, that's actually a good point, Subarna, because high sensitivity troponin, I mean, even in the United States, the uptake for high sensitivity troponin is not complete, surprisingly, because I mean, we've been talking about high sensitivity troponin for the last 8 years now, and a couple of referring hospitals who refer patients to us still use the conventional troponin, yeah, so I think we'll have to just live with what we have and try and see if we can get high sensitivity troponin. high-sensitivity troponin does have its own drawbacks, but again, that's for another day. But yeah, I mean, even where we work in Missouri, a lot of the hospitals around us don't have high-sensitivity troponin.
And there are some additional comments in the chat that say, yes, it takes 30 minutes for the results to arrive. Would that be emergent? And someone else said, in TUTS ER, it takes about 2 hours to resolve.
Yeah, that I still remember those. I'm surprised it still took a couple of hours to get troponins back. But yeah, no, we will get into that. Okay, we will get into the time sensitivity of troponin. Do you really need the troponins or not? The question about the V2 to V3. So that's a good question raised but the problem is, if you have V2 and V3 with ST depressions and you have upright T wave, you have to think about posterior infarct because circumflex artery is very silent. You don't see, sometimes you don't see ST segment elevations when a circumflex artery is involved. And the only way for you to figure out is to do posterior leads or just flip the EKG and see if there is a ST elevation in those leads. But yeah, it's very commonly missed. And until proven otherwise, you would treat it as a STEMI unless you're very convinced that it's not significant. So I think even if you misinterpret it as a anterior, as a posterior STEMI, then you would treat the patient accordingly as a STEMI rather than miss a STEMI. That's what I would say. So it's a STEMI until you have to prove it otherwise. All right, that's the point. And so at this juncture, when our patient has come in, has gotten the EKG, we know it's a RV infarct inferior STEMI. So do we really need a troponin? Now the guidelines say, yes, get the troponin. But in STEMI, you might not have the troponin right away, or the troponin might not be elevated because if the patient presents pretty quick, then the troponins might not be elevated for the first hour and a half. And even for high sensitivity troponin, sometimes you can have troponin that's just mildly elevated. Like let's say if 25 is the threshold, then you have 23, 24, 28, like just very mildly elevated high sensitivity troponin. So for a management of STEMI, for emergent management, the troponin might not be as important compared to when you're managing non-STEMI. You're trying to differentiate between unstable angina and non-STEMI, then the troponin level will be important. But just for management and emergent management of STEMI, it's mostly symptoms and EKG changes. And yeah, you'll send the troponin, but whether you have the troponin back or not might not make much of a difference because you're basing your further management as per the EKG and the patient's symptoms. The guidelines do say you have to send it as soon as possible, but again, for management of STEMI, you don't need the troponin levels back. I hope that answers the question.
Yes.
All right. So the thing that you have to remember, though, is if this is not a STEMI and you're going to manage the patient as an unstable angina or non-STEMI, how frequently do you repeat your troponins does differ according to whether you have high sensitivity troponin or not. Because for high sensitivity, you want to repeat it in every 1 to 2 hours. But for conventional troponin, you have to repeat it in about 3 to 6 hours. So because to see that delta, it does take a little longer for a conventional troponin. All right, so going through the major aspects of acute coronary syndrome management, I had mentioned this before, the process, the time goals, and the reperfusion strategy. Most of the things I'm going to talk about is based out of the 2025 ACC/AHA guidelines for management of acute coronary syndrome. And this is a busy flow chart. I don't want you to focus on everything that's written there. But what I want you to focus on is we've already talked about the ECG goals, that is less than 10 minutes. And what we are focusing on today is that we are at a non-PCI center. And if you're at a non-PCI center, then what are the timelines that we are looking at is what we want to get into. Okay, so go to ECG time 10 minutes. If PCI is feasible within 120 minutes, if you have a hospital close by, if you're in Butwal and Butwal does have primary PCI, then you could transfer the patient so that they could get a PCI within 120 minutes. But if the primary PCI is not feasible within 120 minutes, like our patient, he's in Kalanga in Utah, and there are no contraindications to thrombolytics, then the recommendation is that you administer thrombolysis within 30 minutes of the patient presenting to the ER. All right, so you have 10 minutes to get EKG. Once you see the EKG and the clinical signs, you're going to send troponin, but you don't wait for troponin. You will have to move to the next step to thrombolize the patient within 30 minutes. Now, if you are at a facility which has a PCI, you want to do stenting and everything within the first 90 minutes. But again, that's not applicable to our case here. All right, so remember, it's door to lysis time recommendation is less than 30 minutes. Now the question comes, why is it important to stick to these process goals? Why are we, is there data that supports these 30 minutes, 15 minutes, 10 minutes, whatever time they have come up with? And as you can see this, they have looked into this. So if you have an emergency department wait time of less than 15 minutes, that affects how what the mortality is going to be. If you have hospital arrival time to EKG time less than 10 minutes, that also impacts significantly the mortality of the patient. And when the patient arrives to the first hospital to departure, less than 30 minutes, meaning, let's say, in this patient, we do an EKG in 10 minutes, we see that it is a ST segment elevation MI, we administer thrombolytics and do the rest of the medical management and get the patient out of the hospital within 30 minutes, then that also positively affects the mortality rate. So all of this have been tested, and all these timelines are there because they are shown to improve outcomes in these patients. And the reason we want to do thrombolytics within 30 minutes is this. So as I have mentioned, first 120 minutes, you want to send the patient for PCI because PCI outcomes are significantly better, as you can see here. And as you move outside the 120 minutes window, if you are able to give thrombolytics patients, if this is administered within 30 minutes, those patients actually do better than the patient getting a delayed PCI. All right, it's a little complicated graph here, but again, so first 120 minutes, the data tells us that PCI patients do better if you can do it within 120 minutes. But after 120 minutes, rather than delaying doing a delayed PCI, giving lytics within 30 minutes actually improves the outcome a lot, right? And this has been shown in multiple studies. Okay, so let's go to this. Have you administered thrombolytics in an acute setting? I want to see what the comfort level for everybody is with this.
Because while we look at this, it's maybe worthwhile talking about what kind of thrombolytics and what's available in some of the centers in Nepal, if at all.
Yeah, I would actually be interested to know if what are the common thrombolytics that's available around, because when we were medical students, there was still a big uptake of streptokinase that was being used. Tenecteplase was in the horizon. I don't think we were using it that often. I think stroke patients were getting some of the stroke patients were getting tenecteplase at that time. But yeah, that would be interesting to know what thrombolytics you guys are using. We will go into the different kind of thrombolytics and things that we need to consider before giving thrombolytics in a bit. But yeah, if you could put that in the chat.
In the chat, at least 2 responses saying streptokinase, at least at the district hospital level. Yeah, this sounds like someone also said, given that thrombolytics are luxury in rural parts of Nepal, can we use heparin or enoxaparin in patients that can't be referred? Someone said alteplase, so a mixed response. So maybe streptokinase mostly, or maybe alteplase, maybe in probably like city centers. But that sounds like that's all we have.
Okay. Yeah, the thing with streptokinase now is that we have kind of moved away from streptokinase, especially in the United States, because of all the anaphylaxis and autoimmune reactions that we saw with streptokinase. Now, I don't think I would be the best guy to tell you about streptokinase because, yeah, we haven't used any in the last 6 years. All right. But yeah, no, it's good to see that a lot of the people here have not done lytics before. And so it will be good that we can talk about lytics and all of that so that you guys are a little more comfortable using lytics if it's available. Let me go to this one. Yeah, this is going to be my next question. Do you have thrombolytics available at your workplace? I just want to see what the split is.
The honest answer for me is I don't know. I have to ask because we don't use this typically all the time either. So even for relatively rural ERs that I work in, I would have to ask because we do have STEMI centers nearby, but we're able to transfer these people out. But we don't always have these, if at all. So I do have to replace, I know, for strokes, but I don't know if we can do that for STEMIs that are delayed in transfer.
Yeah, no, I think I'll tell you my experience also because when we were training, when you train, you're at a university setup, so there is always a PCI available, and you mostly never give all these thrombolytics at all. And then once I started working here, and then we had to deal with this 340, 350 kilometer radius of patients with nothing else apart from the hospital that we work in, and then had to start doing thrombolytics quite often. Now it's become like every month or we'll have a couple of thrombolytics patients show up. But yeah, there's a nice split there also. So there are a lot of people who don't have lytics. Yeah, I'm not sure how I can. We can go into the other medicines like heparin and things like that, and we'll talk about that. Those are important. You have to do at least that if the lytics are not available for sure. But I'll come into that. For now, let's stick to lytics, if you have them, how to use them, and what to look for. All right. So, all right. So going back to our case again. So the guy had come in, his testing had started at 8 a.m. He had come to us at 2 p.m. All right. So there was this 6-hour window after which he had shown up since the start of his symptoms. So I want to see, what do you guys think? What is the time window after symptom onset when you can do thrombolytics in patients with STEMI?
I think you just gave out the answer. He said 6 hours.
There's a good split there too, and this has changed a lot in the last 18 to 20 years. Previously, thrombolytics was the only thing that we could do, and the timeline that you could give a lytics was obviously longer. But as the primary PCI has become more common in the United States, the guidelines have changed, and what the current guideline says is symptom onset in less than 12 hours, you can do lytics safely. And you do it if the symptoms onset is less than 12 hours and the anticipated delay to primary PCI is more than 120 minutes. So if you don't have a PCI capable center within 2 hours and patient comes in within 12 hours, you can do lytics. And you can do lytics even after 12 hours if the patient is hemodynamically unstable. If the patient is collapsing right in front of you, blood pressure is low, and has bad arrhythmia like ventricular tachycardia or ventricular fibrillation, and you can't send the patient to a PCI center right away, then at that time you could use it. The guidelines don't say, don't give it a classification, but they just mention that the benefit of fibrinolysis likely outweighs the prolonged transfer of PCI. So if push comes to shove, then you can still do fibrinolytics after 12 hours if the patient is crashing right in front of you. Otherwise, within 12 hours, you could safely administer lytics.
So
Now,
just to confirm, sorry, Prakash, just to confirm, even if we anticipate this patient getting a PCI at some point, we can still give this fibrinolytics for.
Exactly. Yeah. If there is going to be a delay of 2 hours, of 120 minutes, since the patient showed up at your door, and it's not going to be within the next 2 hours that the patient is going to get a PCI, you do the lytics, even though the patient could get it in the next 4 hours, 8 hours, wouldn't matter. You would want to do it within the 30 minutes of that. Because as I showed in that graph, the outcome in these patients are exponentially better than when you just not give the lytics and send them out for PCI that happens after 120 minutes. All right. So even if the patient is going to get a cath later, you do want to do lytics if it's not going to happen in the first 2 hours. So the three most common fibrinolytics we use are tenecteplase, retiplase, and alteplase. In that, and that's with the frequency, tenecteplase is the most common one that we use. And I mean, tenecteplase, I think I looked at this, the costing of tenecteplase in Nepal from stroke, it was about, for stroke patients, I think it was published in 2018, mentioned that it was $450. So that's going to be at least about 60,000 rupees. So yeah, it's not cheap at all. It is available, looks like, in most of the bigger cities. We do have alteplase in Nepal also, which you're going to do a 90-minute weight-based infusion. I don't think we have retiplase that often, and we don't use it that often also because retiplase is not as effective as tenecteplase and alteplase and does not provide any further benefit. The good part about tenecteplase is that if you have it, it is very efficacious, and the chances of intracranial bleed is the least in tenecteplase compared to rest of the other thrombolytics. Yeah, but now I wish I could tell you more about streptokinase, but again, my experience with streptokinase is nil because we don't use it and we don't have it in the United States at all. But there are protocols for streptokinase that you can have with you if you have streptokinase available. And rather than no lytics at all, I would do streptokinase too if you have it. Now, contraindication to lytics is something that has to be in mind. I wouldn't worry much about relative contraindications, except a few, and I'll go into that. But the absolute contraindications we have to be very comfortable with. And most of the times, it's 2 or 3 things that you have to keep in mind. The first thing is you don't want somebody to bleed inside the brain. Okay, you don't want a brain bleed. And anything that puts them at a risk of brain bleed is an absolute contraindication. Like if you have any prior history of intracranial hemorrhage, if you have any AV malformations or any vascular lesions in the head, if there is a malignancy within the intracranial space, be it primary or metastatic, or if the patient has had an ischemic stroke within the last 3 months, those patients are at a high risk of intracranial bleed, and you don't want them to have bleeding inside the brain or the spinal cord. So if they have had any interspinal surgery or intracranial surgery within the last 2 months, if they have had any trauma of the head within the last 3 months, you don't want to give them lytics. The second important part is suspected aortic dissection. If you get a chest X-ray, there's a widening mediastinum, don't do it.
Just a quick comment from the chat. Sorry. Just one quick interjection. There's a message, a comment saying, just for everyone, Sahid Gangalal Hospital provides free tenecteplase for rural district hospitals if they approach Sahid Gangalal Hospital, which is really good to know. And just one question: what are the differences in bleeding risks between alteplase and tenecteplase? Is tenecteplase really highly superior?
So tenecteplase has the odds of having an intracranial bleed is 32% less with tenecteplase compared to alteplase and retiplase. So it is superior in terms of intracranial bleeding. Apart from that, tenecteplase is more of a genetically engineered alteplase. It's a similar chemical as alteplase, it's just genetically engineered. And yeah, the data tells us that the intracranial bleeding is less with it. It does still cause GI bleeding and other bleeding, but the chances of intracranial bleed is less with 1080 bleeds compared to the rest. Yeah, I would say that it's the efficacy of 1080 plays is not drastically better. I think it's more about the safety profile, and yeah, and it's because of the less chances of intracranial bleed is why we use it more often. So yeah, any active bleeding, you don't want to do any of the thrombolytics. And if the patient has severe uncontrolled hypertension, and uncontrolled is unresponsive to therapy, including IV esmolol or IV nitroprusside or nitroglycerin, whatever you're using. If the patient is unresponsive and the blood pressure, despite your best efforts, is still above 180 over 110, then don't do lytics. But before you say that they're uncontrolled, just try and treat the elevated blood pressure with some medicine and see if you can get it to a safer range. Now, a lot of times, what helps, and I found that with experience, is you put them on blood pressure medicines and still the blood pressure is high, and that will delay your lytics administration. In these patients, they are so ramped up because of anxiety, stress, pain, that giving them just a very small dose of anxiolytics with like whatever midazolam, 0.5 milligrams or something, it's going to calm them down. That will drop their blood pressure quite a bit. So sometimes blood pressure medicines might not be the only way to do it. You would want to give them some anxiolysis or some pain support with morphine or fentanyl.
Okay,
and that
so
also,
we got a question in the chat asking if it is okay to give morphine in this situation. So you're saying it is okay?
Yes. Yeah. Morphine as a adjunct in STEMI is not always a first line. If you want to use anything for pain management, you'd first start with nitroglycerin, unless they have a RV infarct, which we talked about, right? So you want to use nitroglycerin or nitro-drip to see if that helps with the ischemic pain, and that also helps with the blood pressure. So that would be the first line. But despite using nitro, if the blood pressure is still high and the pain is not better, then yes, you can use morphine or fentanyl. You can use up to 4 milligrams of morphine. So yeah, we can go pretty high. Or you can use 25 milligrams of fentanyl, and that usually does the trick. Now, among the relative contraindications, the most important thing usually for when you're managing these patients is somebody who's had a traumatic or prolonged CPR. Because sometimes these patients come in with cardiac arrest. You do CPR, you revive them. If you have done CPR for more than 10 minutes, don't do lytics. Time to transfer the patient out. Intubate the patient, start the patient on all the heparin, aspirin, and all the medicines which we'll talk about later, and get them out. For CPR, the guidelines mentions more than 10 minutes. But if you ask me practically, if the patient has had a CPR, at least 1 or 2 cycles of CPR, I don't give them lytics because the risk is just too high.
Whereas we have about 12 to 13 more minutes because we start kind of late.
Sure, yeah. I will move quickly. So the adjuvant therapies that we talked about. So oxygen, you don't want to put everybody on oxygen. You want to do it only when the saturation is less than 90%, all right? And analgesics, I mentioned, you want to do nitroglycerin or sublingual or IV nitroglycerin, then only go to morphine or fentanyl if they're resistant. You want to do dual antiplatelet therapy with aspirin. And in the United States, we use 325 milligrams of aspirin followed by 81, and the dosing might differ in different parts of the world, but yeah, those range is what is usually recommended. For clopidogrel, you want to use 600 milligrams. Sorry, it's not daily. It's once followed by maintenance therapy of 75 milligrams daily. You want to put these patients.
Sorry, a quick question about it. So we had a question, kind of an interesting question in the chat. It said, I work as a telehealth service provider, and not all health posts have ECGs. Is it okay to give clopidogrel and statins to these patients, high-risk patients that present with chest pain? So I said we would just discuss this.
Yeah, no, that is interesting. So if you don't have the EKG, then yes. If the patient has chest pain and there is a high likelihood that the patient has MI, I mean, if the chest pain sounds anginal, then yes, you would do a aspirin, you would do a clopidogrel, and if no contraindication, you would even do a heparin if available, and then send them out to a center where they can get EKGs and further evaluation. Yes, because what I'd like to say is any of these medicines is better than nothing. So you would want to do at least most of whatever is recommended before you send them out, depending on what is available at your center. Because if you have statins, you would want to give them statins also, and heparin, and then aspirin and Plavix, and then send them out. Because they used to manage STEMI not that long ago with just these medicines. And
a question of my own about antiplatelet agents, Prakash. So a lot of times we here, at least in the United States, give ticagrelor for patients who are getting PCI. Is that something you would prefer to do it just prior to cath lab? You want to make those decisions, or do you want us as ER physicians to give that medicine? So what's your thought about that?
Yeah, no, that's a very good question. It's a very nuanced question also, and I wish there was a very, very clear answer to that. But a lot of times, the only reason we don't want people to give clopidogrel when they are transferring right now in my practice is that I'll go and do a coronary angiogram, and if it looks like the patient is going to get a bypass surgery, then they'll have to wait 5 days to get the bypass surgery, unless it's an emergent bypass. They'll have to do it after 24 hours. But yeah, that will delay the bypass time. But nowadays, with primary PCI, I would say go ahead and do aspirin and Plavix or Brilinta or Prasugrel. Brilinta meaning ticagrelor. Ticagrelor is good in that regard if you're going to give it in the emergency room, because you have to wait only about 3 days before you can do bypass surgery. For clopidogrel, you have to wait 5, and for Prasugrel, you have to wait 7. So the amount of wait time to get a bypass, if they need bypass, is going to be shorter with ticagrelor. But if you're doing lytics, I would say go and do aspirin and do clopidogrel also. Or because I wouldn't use ticagrelor or Prasugrel with lytics because there's no data. The only data is for clopidogrel. So if you're going to do lytics, do aspirin and clopidogrel. If you are going to not do lytics and send the patient out, then you can choose from either of the three.
Did you say either of them?
That's right.
Okay. So in a recent class by a renowned cardiologist in Kathmandu, he preferred ticagrelor. And for us who have just practiced or who just have availability of ticagrelor, we often get confused which one to use.
I see. Yeah. So I'll tell you, this is the data on ticagrelor and Prasugrel. There have been multiple studies individually, and there's just been one study which has compared both of them together. So ticagrelor and Prasugrel are more efficacious in the setting of ST segment elevation MI compared to clopidogrel. So if you have them available, you would want to do ticagrelor or Prasugrel. The problem with Prasugrel is if you're more than 75 with history of stroke, you don't want to use them. So that's why most people have gone to ticagrelor. Issues with ticagrelor is side effects. A substantial portion of patients do have shortness of breath and immediately after administration of the first dose. And then we have to switch those patients to clopidogrel or Prasugrel. All right. So and you'd want to do nitroglycerin for pain control and blood pressure control, aspirin and clopidogrel or Prasugrel or ticagrelor, heparin. Heparin standard dose is 60 IU. That's like I usually give like 4,000 units at the get-go, and then start them on a drip of 12, and then give them statins if you have it. Statins usually atorvastatin 40 or 80, rosuvastatin 20 or 40. All right. Given the time crunch, I'm just going to move a little quick here. So there are certain nuances to using antiplatelet therapy after thrombolytics, which everybody has to remember. Okay. As I mentioned, clopidogrel is the only one that's been studied. So ticagrelor and Prasugrel have not been studied much. So after lytics, you would want to do clopidogrel. The loading dose after lytics is not 600. For normal individuals, it's 600. But after lytics, you'd want to do 300. And if the patient is more than 75, just do 75 of clopidogrel. Don't give them 300. The chance of bleeding is just high. All right. And the dose of heparin after lytics is the same. You give 60 IU, like 4,000 units bolus, and then start at 12 drip. If you're doing enoxaparin, there are certain nuances to it. It is going to be difficult for you to remember it. We have it stuck in our ER if we're going to use enoxaparin, and you have to just memorize or stick it in a place where you can have easy access to, because there's differences if you are less than 75, over 75, and sometimes it might be difficult to remember. But if you are using Lovenox or enoxaparin, then the dosing is going to be different. All right. Do we need a cardiologist to do lytics? Multiple studies have said no. There was this study, it was a proof of concept study where they had the EMS people give lytics when they go to the patient immediately after. If the patient cannot get a PCI within an hour, they would go to the patient, and all these technicians who are not physicians would go in and give lytics. And then they would take the patient for PCI later. And the PCI would be done in 6 to 24 hours. And what they found out was that the outcomes were not different from primary PCI. If they gave lytics and then did a PCI later, 6 to 24 hours later, the outcomes were not that different from just taking the patient and getting a stent. So yes, even technicians can do it. And the chances of bleeding obviously is higher with fibrinolysis compared to primary PCI. But when you compare this data to cardiologist or ER physician administered lytics, it's not that different. So just because you have a technician give lytics does not mean that it's going to cause more bleeding. You just need to be careful about what the contraindications are, and they have to be trained about it. And more locally, there's been a study in India that they have had emergency physician initiated thrombolysis. And what that showed was, it showed good success rates, and there was no significant increase in complications rate when EP physicians without cardiology input administered lytics. So it can be done with ER physicians, does not need to be a cardiologist. And I do that all the time. I call, when they call me for a STEMI, I just tell, if the transfer time is going to be more than 120 minutes, I just tell the people, just give lytics. And the emergency physicians here are pretty comfortable around Missouri to do that now. All right. How long do you think the patient should be monitored after receiving thrombolysis? Given the time crunch, I think I'll give you a few seconds if we have any respondents. Otherwise, we'll just move ahead with this. Okay.
That's it. Transfer immediately.
That's right. Transfer immediately. There is no monitoring time, because you want to get them out of the door in 30 minutes. Remember, 10 minutes EKG, within 30 minutes lytics, and within 30 minutes you want to get them out of the door. So transfer them immediately, because regardless of the outcome, after you've given the lytics, there's nothing else that you're going to change in that patient's management. You're going to put them on aspirin, clopidogrel, heparin. If they need nitro, you're going to do that, and you're going to give them a statin, get them out. Okay, so don't keep them for any monitoring. Yes, there is a risk of bleeding, there's a risk of intracranial bleeding and all of that, but there's nothing you can change in that scenario. Just get them out to a PCI-capable facility. And then at the PCI-capable facility, they can make a decision about when they want to do an angiogram, when they want to do a stent, and all of that. For PCI, it's important to get the patient out immediately, because there is a 24-hour window where you want to do PCIs. Because after 24 hours, unless there is life-threatening ischemia or arrhythmia, we don't do stents, and we manage these patients conservatively. All right. So you would want to get the patient out of your emergency room as soon as possible, so that they can meet this 24-hour window. The reason we don't do after 24 hours, we don't do PCIs unless the patient is having ischemia or arrhythmia, is because of these trials which they've done. This is the OAT trial, and it showed that there's no difference after that. Doing PCI or not, they can have similar outcomes. And this shows that with primary PCI, the mortality rate has gradually decreased along the years in the United States. What I do want you to focus is in this blue graph, which shows that in 2015 to 2018, the mortality rate for 0 to 30 days in the United States was around 5.8%. And the reason that is important is, it'll come in a different slide. what this slide shows is that if you have a process that's built up, then how far do you live from a PCI capable center has no bearings in what the outcome is going to be. It's just that we need to get the process right. You need to get the lyrics in and get the patient out. And if you stick to the process, these patients do pretty well. And distance from a hospital will make has no implication in the outcomes. And this is data from northern United States. I mean, the transport system here and all of that is different. So that's going to have a key effect for sure. But it's doable. As you can see here, door to device time in these patients was just 137 minutes. It's not going to happen in Nepal. 137 minutes, even when you're living more than 160 miles or 100 kilometers away, is not going to happen. But something that we can definitely work towards. In Nepal, this is data that I got from Nepal. If you do primary PCI, the mortality rate is not that different. As you can see, 5.8 in the United States, 2018. Nepal, this is from Bharatpur. This is from Gangalal. This is from Manmohan. And you can see that it's around the 5 to 6 ballpark. If you can do primary PCI, in-hospital mortality in Nepal is actually comparable. But where the problem lies is, this is data from Marsden campus and Gangalal at different times. The median time between onset of symptoms to presentation for the transfer patient for us there is 28 hours, 32 hours. So it's outside that 24-hour window where we want to do PCI. So a lot of patients are getting transferred. They come in late. That's why lytics are important. Because what that will do is that will at least get the flow going while the patient gets transferred and drastically improves outcome. As you can see here, this was interesting data from Gangalal. So mode of transfer for referred patient, you can see that even after patient has STEMI and is being referred, 2.9% of people are put on a bike and are taken to Gangalal, which was very interesting. They also looked at what has been done in the outside hospital prior to transfer of the patients. And Gangalal data shows that lytics were given in only 5.3% of the patients. So this is definitely something that we can improve to improve patient outcomes. And you can see that what do they do at Gangalal and Marsden campus is after the patient is transferred, 26% of people get PCI, 33% of people get PCI. The numbers are low. The reason is a lot of patients are reaching the institution 24 hours after. And at that time, the recommendation is don't do PCI, just manage them medically. So a lot of people miss the chance to get lytics or stents because they reach their late. And this is data from Europe and Middle East. And you can see that over 90% of the people get PCI or fibrinolysis. Even though we lag behind in PCI, we do lag a lot behind in fibrinolysis also. And that's an easier thing to take care of than set up a PCI center, which is going to take more time and effort. And the issues with conservative management, this is data from teaching hospital, I think it was data from 14 and 15, is that over 1/3 of the patients start having cardiovascular or bad outcomes, including heart failure in 22% and death in 11%. So transfer of the patient is going to be important. So when you are coming up with a chest pain or STEMI protocol for whatever you work in, identification of the nearest PCI capable facility is going to be important, and timing of their cath lab. Does it run 24 hours? Is it just a workday cath lab? That's going to be important. Finding variable options for transportation and starting to open up communication channels to the emergency room where the PCI is available and with the cardiologist, if possible, is going to be important also. So yeah, giving the lytics and getting them out is the key. So now this patient, going back to our case. So this guy, I mean, this is, that was a case in Nepal. This is the one that I did day before yesterday. Similar story, same, that was the EKG that I've shown earlier, and we've done that right side lead. And this is his right coronary artery. And you can see in this picture, his right coronary artery is completely occluded in the mid to distal segment. And it was a very tortuous right coronary artery, needed a lot of support, needed a guideliner, and a bunch of stuff to be done. But then we ballooned it and put it a stent, keep a large 4 by 26 stent, and yeah, his right coronary artery opened up. Well, and this patient has already been discharged after 24 hours. All right, so I want to show you this picture. The picture that you can see to the rightmost is the patient that I had given lytics last month. He had come in with an anterior ST segment elevation MI, and it was left anterior descending artery. As you can see, let me pause it here. This is the left anterior descending artery here. And he had a blockage right here. The lytics had lysed some of the clot, and there was a small channel that had opened up that had reconstituted flow to the distal left anterior descending artery. And this patient, we did a PCI after 6 hours because it took time for him to get transferred. And then, yeah, he did pretty well and got home in 48 hours also. So yeah, lytics do help. They help. They might not take care of the whole clot burden, but they will open up at least some channels to get some blood flow through so that the patient can make it. And this is another inferior STEMI that we had last night. And yeah, patient came in with a right-sided infarct. The right coronary artery is completely gone, got a stent to his proximal to his right coronary artery, and that was opened up. All right, those are my references, and thank you. Any questions, anything that we can discuss further?
So there was just one question in the chat that we have not answered. Is there any difference between fentanyl versus morphine for pain control? Because some evidence apparently shows that fentanyl is better in terms of platelet inhibition. I don't know if that's like practically or clinically significant yet.
Yeah, I mean, this is what I said. I will not make my choice of morphine or fentanyl thinking about the platelet inhibition as such. I mean, it might be something that I might need to study myself. If how much of a platelet inhibition action does fentanyl have? If there is evidence, yeah, it's a good thought. All right, but I would use whatever is available because controlling that blood pressure and controlling the pain so that we can do lytics and we can provide symptomatic control is going to be important. But yeah, because with platelet inhibition, we are already doing aspirin and P2Y12 inhibitors. We're having the patient on heparin drip already. So I don't think I would base my choice on it, but yeah, no, that's good to know. And I definitely research that.
Okay, so we'll just give like 1 or 2 more minutes if there's any other questions. There's one question in the chat, LED 100% blockage at ostium with Ramus 70% block, CABZ plan, is it not emergent condition to perform CABZ? So,
okay. Yeah, so.
Yeah, go ahead.
Yeah, I mean, that's a good question. So if you have a LED that's 100% blocked off and a Ramus is at 70%, is it an ostial LED and ostial Ramus or?
So LED at ostium, but Ramus, it doesn't say where.
I see. So to tell you the truth, nowadays with the advent of intravascular ultrasound here, we can actually land a stent pretty well at the ostium of the LED, and we still stent those. I have stented those, but if it's there's always a worry that you might extend that stent into the left main coronary artery, which you don't want to stent into the left main coronary artery. So bypass surgery is not a bad option at all if it's available. But if emergent bypass surgery is not available, then even stenting the ostium of the LED with intravascular ultrasound can be done. So yeah, that by itself should not be a thing to send the patient for bypass in a STEMI setting. If it's a non-STEMI and you think that the patient can wait, then that will be a different deal. But here the LED is completely occluded. You're going to have a bad anterior infarct. And yeah, I would call my surgeon, talk to them, and if we can do this emergently, not a bad idea. But most of the times I just stent it because it's safely stentable. Okay.
So with that, I think we should stop here. And if there are further questions, I'm sure there will be a lot of questions after the session. You can email those questions either to me or to Dr. Ramu, and then we can ask Dr. Prakash to provide answers, and we can get those answers to you. Is that okay, Prakash?
Definitely. Yeah. I hope this was helpful.
Yeah, or email to info@hapsa-nepal.org, and we will try to get those questions answered. Thank you, Prakash, again, for this really wonderful session. I think it was really useful and very relevant and a very common problem in our rural Nepal. And I think it was really well adapted to our rural setting. So thank you very much. It was really wonderful.
Thank you, guys.
Just so you all know, Prakash is working today. He blocked like 1.5 hours of his early morning hours for us. So once again, we're really grateful. Thank you very much, Prakash.
Thank you, guys. Everybody have a good night and a good day.
All right. We will end this session soon. Just a quick word reminder about the upcoming Rural Trauma Conference in May. You all already have gotten the flyers and the QR codes to register. And once again, I will let Dr. Ramu tell you the phone number for the Poison Control Center. Just keep it memorized so you can share with all your friends. It's open 24/7, and because we see toxicological poisoning cases all the time in all the settings that we work at, it's an important number to remember, and it can be very helpful. Once again, 01-1490877.
Yep, please save that number. And the conference, if you can join, most of us will be there. So you can check out more at, let me just put our website here, .org. Okay.
And remember the website www.hapsaglobe.org, and your questions can be sent to info@hapsa-nepal.org. And I will share the post session feedback form once again.